All right, everyone, welcome back to another episode of Christianity on the Spectrum. This is a podcast of around 12 years of ethnographic research into autistic Christian and ex-Christian online communities, how they act, how they behave. And on this podcast, we'd like to talk about various topics like autism, Christianity, and sometimes a mix of both, sometimes one, sometimes the other. And I think this conversation is probably going to be one of those, a weird mix of both, because someone paid a very large amount of money to the Against Malaria Foundation and then sent me an email asking me very politely if I would consider doing an episode on the various ethical questions around selected abortion and IVF. And I thought, well, why not? you clearly have spent money on the Against Malaria Foundation. That seems like it sort of fits with this podcast's themes and topics. So sure, why not? Let's talk about that. Let's do an episode on that. And so to help me talk about that, I have Lauren from the Rehumanize International, is it?
Yeah, Rehumanize International, yep.
There we go. Yeah, she was on a previous podcast about autistic people in the Christian pro-life movement, and she knows a lot about this. And so I thought, why not have her on? She's also autistic and Christian, so it fits. So anyway, so for the folks who haven't listened to that episode, do you want to sort of explain who you are and what your organization is?
Yeah, of course. Okay, so I am Lauren Pope. I am the executive director of Rehumanize International. We are a consistent life ethic organization, which means that we oppose all forms of aggressive violence, specifically state-sponsored or allowed forms of violence. So that includes things like abortion, euthanasia, death penalty, police brutality, war. Basically, if it is killing someone, we oppose that. And we also are trying to build a more humanizing world.
Cool. Yeah. And also, sadly, they do not consider AIs to be people that need to be protected.
I will say it's a question of if the AIs, like, how are we treating them if they have sentience? It's, not people, but not treated badly, I think is where we're...
I think it's destructive to your soul to treat an LLM poorly.
I agree.
It's one of those ethical questions where I think it's obviously wrong to do it, even if it isn't a person. But
right, yeah.
We still have time for them to develop sentience. We'll see. But okay, this podcast isn't about that. Let's not get off track. Okay, so the topic for today is the ethics of selective abortion and things like that and of that nature, or of just fetal screening or pre-implantation screening and the various questions around that. So before we even start talking about the ethics of it, it's probably a good idea to define what it is. So let's start with that. So what is selected abortion?
So selective abortion, we're going to differentiate from a general abortion in that it is more a abortion for cause. Maybe it'd be a good way of thinking about it, right? Like, this is not someone who is having an abortion because they are not wanting to be pregnant. Generally, they're having an abortion because they have learned some specific information about the unborn child that makes them think that the pregnancy cannot continue, and at various stages during the pregnancy as well. But that's
So the difference between selective abortion and abortion is that in an ideal scenario, had they not known this information, they would have carried this pregnancy to term and they would have had this child. But now they are deciding to end it. So right. There are lots of different reasons that this happens. Can you just go through some of the reasons? I mean, I put them in different tiers of severity. Yeah. So I think let's start with the first one, which is serious anomalies or serious fatal issues.
Right. So I would say the first category would be conditions where the doctor has told them that their child has a condition that's incompatible with life. So that would be some serious brain anomalies. Some of the trisomies would fit into this category, although I'll kind of discuss why that's not entirely true as we go on. And just various things that the doctor has told them that if your child makes it to birth, they are going to probably pass very quickly following birth. And also, here is what that might look like, and that might include a lot of like pain and suffering and things that the parents are trying to avoid by having that abortion. And that's very much how it is presented to the parents. And I think it's important to understand that these parents are being told that is what is going to happen. If your child is born and they survive to birth, they are going to be in a lot of pain and suffering. And so that's the mindset that they are operating under when they choose to have the termination.
Yeah. So I know one couple who had this. They basically did a scan and they found that that the baby was basically missing a large portion of their brain and a bunch of critical organs that it should have developed at that stage. They did the ultrasound and they just weren't finding the things they needed to find. And so they were like, the only reason this fetus is developing is because it is hooked up to you, and the second it becomes untethered from the mother, it will die. And so they just went ahead with the abortion. So you have issues like that where there it's like no matter what happens, something's going to go down very badly pretty quickly.
Yeah, and what I'll add to that too is that there are some things that are more educational when it comes to that, especially like I said, the trisomies, where actually like getting proper care is hindered by having a prenatal diagnosis. So potentially you could have had, and there are cases of children who have several of the trisomies who go on to live into their teens, but it is at least a very medically precarious situation, I think, is like the baseline here. Like your child is going to have a very like medically fragile life for sure if they were to continue their pregnancy.
Yeah. And then there's sort of, I would say, like the next category down, which is like they're not going to die,
right,
but they're going to have a much worse quality of life. So can you talk about that category?
Right. So I'll say then you have things like Down syndrome is one that is very frequently selected for abortion. And then you have conditions like spina bifida. You have some of the conditions that are like a heart condition or a kidney condition, or things where they're like, okay, this is going to result in multiple surgeries to correct, those kind of things where it's not a universally fatal diagnosis, but it is, we'll say, a life altering and potentially life shortening diagnosis that you are.
Yeah. And so that's sort of the one that is most relevant to this podcast and probably most relevant to the discussion that the person who requested this episode was interested in hearing about, because that's where things get, I think, a lot more medically complicated. In the first case, even if you believe that abortion is murder and you're killing someone, you can easily justify that as like mercy killing. Like you are someone's trapped in a burning vehicle and the revolver's on the dash, you take the revolver and put them out of their misery, type of thing. That is at least less ethically ambiguous. It's not still not ethically ambiguous. It's just like there are fewer questions in that one. But this is a category that gets talked a lot about, especially in disability communities, where it's like this child is going to have a much worse quality of life than every other child. So, we should end it and you should try again. And then there is a final category, which is things that just aren't life-threatening at all, but are up to the preferences of the child. So can you talk about some of those?
Yeah, so the first is obviously sex selection abortion. That is the biggest and probably most prevalent in this category, wanting a specific sex for your child. Then I would say limb differences also would fall into this category. Things as simple as an extra finger or a club foot. Like these are reasons why people do have abortions, even if there are no indications of anything else that would be wrong with the child beyond that relatively minor physical disability.
Yep, there are also some cases, these are more rare, but they do happen, where especially when you're getting into surrogacy, where when you're doing surrogacy, you do multiple implantations in case one of them doesn't take. And what happens if you get multiple implantations that take and the couple only wanted one child? Then there are cases in which they will abort one of those children, not because it's not a healthy fetus, but because they just only wanted one child, and now there are two in the surrogate's womb.
And you see that, especially with like higher order multiples, they'll have something called selective reduction, which means that one or more of the fetuses are aborted so that one or two have a better chance of going to as close to term as you can get with multiples.
Yeah. There's also a sort of new category that is just popping up, and it's mostly just popping up because of the advances in IVF technology, which isn't quite abortion. I don't know. Do you guys consider it abortion, the
Yeah,
IVF pre-implantation?
yeah. I mean, it's anything that's destructive of the embryo. We are considering it to be a abortive thing. It's it is killing a human being, but it's a situation where they have pre-implantation genetic screening. And I guess a caveat there would be that you don't necessarily have to destroy or kill any of the embryos. You could just have the information and then just like still implant them all and do with it as you will, just as like a little bonus of information about your children. But the way that it is mostly used now currently is you are able to get different kind of indications for different genetic markers for everything from intelligence to height to the risk of Alzheimer's, heart disease, diabetes, like all of these things, in addition to also like actually having Down syndrome or another genetic condition, and have that information before you do implantation. And the way that people use this information is to basically pick and choose which of the embryos that they think has the best qualities of the cohort and implant that embryo, and then usually either destroy or freeze if they plan to use all of them, the remaining embryos.
Yeah, this is something that's popular with a certain type of autistic person on Twitter, at least.
It
Uh,
very much is, yes.
yes, this is like the low feelings tech autist. This is their preferred method of having children.
Hmm.
Is
Hmm.
have genetic pre-screening IVF is a really big thing in those types of communities, because they think, well, why wouldn't you want to give your child the best genetics that it possibly can? Why would you want to just roll the dice and see what comes naturally when you could select the embryo that's going to have the potentially highest IQ and then leave the rest? But yeah, so there are also other cases of this. So a couple that I know, the father had a rare genetic disorder, and there was a 50-50 chance of it being passed on to their children. And so they did IVF, they did genetic pre-screening to see if that genetic disorder was in the embryos, and if it was, they didn't implant, but if it wasn't, then they implanted. And
Right.
so you can also have situations like that. That's more common with things like BRCA1, BRCA2 genes, because those are pretty easy to test for. So
Yeah,
for those who
cystic
don't know,
fibrosis is another one that
yeah,
they can do
yeah,
and that's really where like this pre-implantation screening came from, screening for like these specific genetic conditions, and then has kind of moved into the
yeah, and now you can select for eye color
right,
and
exactly. Yeah, they have a little
and sort of,
chart. You can, yeah,
yeah, yeah. Those feel pretty dystopian to me.
yeah,
Those feel very weird.
yeah.
Just vibes based.
Yeah, the
Um,
vibes base is very strange, especially because it's very humanizing in one way. Because you're like, oh, this particular embryo has blue eyes, but screw them because their IQ is 120, so I don't want that. Like that's a very
yes,
weird dynamic to have where you're think both of
yeah.
those things.
It also, we haven't had a lot of children born from this yet, from this specific like selective method, and I just wonder the sort of psychological impacts this will have on them,
Yeah, I definitely
sort of
want to talk
long
about
term, to
that.
realize
I
that
have I have a lot of
they're that.
thoughts about that. We
Okay,
can get into.
yeah.
Yeah.
Yeah, okay. So I think that's a good enough definition of what this actually is. Do you have anything else you want to add for, like, when we're talking about this, what do we actually mean?
Yeah, so I'll just say like when these things are happening are at various different points during the pregnancy. And I think that's also important to note that, like we're saying, some are like pre-implantation, some are first trimester screenings, which is not a like accurate your child has this condition or doesn't have this condition. It's more like there is a range of possibilities and you have a higher risk of this condition. And then there are specific genetic tests like chronic life sampling and amniocentesis that tell you definitively if they have a specific genetic condition. Also, there are some blood tests that are fairly accurate, but they're still not quite as accurate as like those more invasive tests. And then for the ultrasound, so for picking up things that are like your friend who had a baby that had missing organs or like that kind of thing, that's going to be usually at the 20-week ultrasound when you make that discovery.
Yep. So I've now been through this process twice, and having been through this process twice, usually, I mean, both times we turned down the early warning screenings just because my wife was like, there is no way you are ever going to convince me to abort a Down syndrome child. I don't think I'd be able to live with myself if I had that weighing on my conscience. I don't think I'd be able to look my next children in the eyes and tell them I love them if I was willing to get rid of a Down syndrome child. And I just feel it's wrong. And so we're like, okay, well, yeah, I guess there's no point in doing the Down syndrome screening if we're not going to take action on it. But the anatomy scan, I think, is pretty straightforward. And then there, it is important to note. So I do have friends who have had the screening, and the screening isn't like, yeah, this child has Down syndrome, like you said. It's more like this child has a bunch of markers that could indicate. So it's more like you're talking about risk factors. And they were told, like, this one couple was told that there would be like a 70% chance ish around that their child would have Down syndrome. I've heard other ones who were told there's probably like a 20 or 30% chance that this baby has Down syndrome. I don't know if they actually get like the doctor telling them the percentage, or if it's just like what their rough sort of estimate is, and that's how they explained it. But yeah, can you talk more about that and how?
Yeah, the early screening. Yeah, and I can talk about it in terms, because my oldest son, kind of, we followed this sequence, so I can tell you how that worked in practice with him. Now he is 21 years old, so some of this is technology has progressed beyond this, but I'll tell you how it's still fairly similar. So with my oldest son, we did just have like the normal standard screenings, because it was just presented to me as like, we're doing this blood test, and it wasn't even really like an option. They just, we're doing the blood test. At the time, it's called the triple screen. Now it was like quad screen. They added something, but we're doing this test, and it will tell you if you have a lower or higher risk of having a child with Down syndrome, but other conditions as well that it can kind of have markers for. And so I had that test done, and it came back elevated, that it had an elevated risk. And so, but I had also been having some like bleeding issues and things like that. And they're like, sometimes that just throws off the test. Like, it's not super precise. If you have any kind of issues early in the pregnancy, it can, mess things up. Like, don't be too concerned about it. Also, I was young, so my otherwise risk factors were low. But they're like, but because you had this higher risk, we're going to go ahead and do a more thorough 20-week ultrasound, right? Instead of just kind of like the standard 20-week ultrasound that's done for everyone, we're going to send you to a maternal fetal medicine doctor, and they're just going to do a little bit more in depth of a ultrasound, because specifically what they really are looking for there is, one, the Down syndrome markers, but also because of the spina bifida, they want to really like get a good look at the spine and make sure that everything is developing normally there. And so you could go to the higher risk doctor. And so I did. I went to the higher risk doctor, and they said, okay, no, it looks fine. Like, I don't see anything that would be more concerning at this point during the pregnancy. I think that you're fine. I wouldn't recommend you do anything else beyond that. But if there had been something where they're like, you know what? Yeah, I do see some other markers. Maybe we should do this. Then that is when they would probably say, okay, now I would recommend you getting an amniocentesis to like definitively test if there is a chromosome abnormality, or if they had seen the spina bifida, then we would start talking about, there are fetal surgeries for spina bifida even back then. But some people would choose abortion at that point. And so it's sort of a pushing you through this funnel towards like if you're going to get a diagnosis or not. That's where we were. We're like, okay, cool, things look good. Then my water broke, and that was very traumatic at 22 weeks. And so that, of course, changed the whole course of the pregnancy. They luckily were able to keep me pregnant through a lot of medical intervention. I stayed pregnant for 7 more weeks, so that was fantastic. But because of that, I was then having ultrasounds every single week to, monitor the fluid levels and just the growth and all of that. And that's when they came back and they said, his limbs are disproportionately short. We're now seeing this as we've gotten further down this pregnancy. We didn't stay at the 20 weeks, but now that we're going into the 3rd trimester, like, his limbs are really short. We think there's a very good chance that he has Down syndrome. But given that your water broke, obviously we can't do an amnio at this point. Like, that's not going to happen. So we'll just test when he's born, and we'll see what happens. And so then he was born. They immediately ran the genetic screen, and he didn't have Down syndrome. And they were just like, well, it wasn't a super intense, like, full, geneticist screen. It was just like the very basic, chromosome analysis. Now, if he doesn't have Down syndrome, that's good. Good luck. And it was sort of all of the prenatal stuff was ignored at that point, because, they had a lot more to focus on, because they had this tiny little baby who was 2 pounds, 4 ounces and, trying to live in the world. So everything else just kind of got pushed to the side. But then many years later, we found out that he actually does have a genetic growth disorder called Russell-Silver syndrome that causes, it's a pituitary growth disorder that causes a lot of those issues that we were seeing. So all of those, that to say, all of the testing that was kind of showing some irregularities, it wasn't pointing to what they thought it was pointing to, but it did pick up on something. He does have this genetic growth disorder. It probably was seeing that, but it wasn't something that was in their funnel. So it was kind of out of scope of what they're able to pick up. So that happens, right? Like you have things that are on the radar that they are looking for that they can pick out pretty regularly and then walk you through if you are going to continue the pregnancy or terminate. But there are a lot of things still that are just sort of like out of scope and they're not going to pick up on everything. And so just because you have like all clear from all of these tests and, you know, everything looks good throughout the pregnancy doesn't mean your child won't have a genetic disorder later down the line. It's just they didn't get picked up with what the current technology can show in a pregnancy.
Yeah. So that's sort of the false negative side of things where they don't pick up on something that is there. But then there's also the false positive side of things where they do pick up on something and something isn't there. So do you know generally how common false positives are in this?
So it depends again on like the specific test. So the different tests have higher rates of false positives. Generally, the tests that are the most like just a screening test, those are going to have the highest rates of a false positive. Whereas when you kind of like drill down and get something that's more specific, those tend to have lower rates of false positives. But I mean, it can happen like there's a blood test you can get early in the pregnancy now that tells you if you're having a boy or a girl. Like it's literally, that's all it is. It's just, are you having a boy or a girl? Which you would think that's a pretty straightforward test, right? But even that can be wrong. I have a friend who thought she was having a girl and then she got to the 20-minute ultrasound. They're like, oh, nope, that test was wrong. Sorry, it's actually a boy. So even like just very simple chromosome analysis can be wrong. And so it's one of those things where, and usually the doctors will kind of give you a range of like, this increases your chance of it by 30%. And it's just going to be what that particular screening is picking up. And it's, varies by company and all of that.
Yep, that makes sense. There, famously, we have countries like Iceland. So Iceland has, I believe, and you can correct me if I'm getting my facts wrong here, I believe they have mandatory screening for early pregnancy, or it's maybe not mandatory, but it's offered for everyone.
Yeah.
And so they also have an extraordinarily low rate of Down syndrome birth.
Right.
Yeah.
Yeah, it's basically 100% of babies with Down syndrome are aborted in Iceland. They have almost no children with Down syndrome born in Iceland. And yeah, it's part of the prenatal packages that you're going to have this screening. So I'm sure if you were like really adamant, they probably would let you not do it. But if it was like you made a huge stink, but just as part of their standard prenatals, they are screening for this. And yes, Iceland is extremely high for the number of abortions due to Down syndrome, but every developed country is extremely high. I mean, it is something that in America, the number is 67%, which I know because when we posted a video of it, we got all the kids going 6-7.
Oh God.
Yeah, we're like, okay, guys, like read the room. But anyways, yeah. So in America, it's 67%, and that is actually on the lower side. Like most of Europe is in the 80s and 90s.
Okay. Yeah. So I think when we're talking about this, I think there's a pretty good case for selective abortion in the case of serious fetal anomaly, right? My general sense is like, yeah, that I can see that. I'm guessing that's not the case for Rehumanize.
Right. No, I mean,
yes.
I'll kind of explain the reasons for why we don't take that position. The first one is the termination process itself. And I think that people have in their mind where if we do the termination during pregnancy versus allowing there to be a birth and a natural death, that the termination is going to be less painful for the child. And that's like a very, very big motivator for the parents. Because like I said, like these are parents who want to have this child, care about them very deeply, and have been told like they are going to suffer a very painful death. And so they are obviously like would want to prevent that. And that's a very like human natural thing to not want your child to suffer. So they're told like, we can do this termination and then you can hold your baby afterwards. Like it is presented as like the more humane option. The problem is the actual mechanism for inducing fetal demise is by injecting drugs into the heart, which triggers a heart attack, which is not a painless process, right? I think we can have a discussion. Is it more painful to have dying because you are having trouble breathing versus an induced heart attack? But neither of these things are painless. And so it kind of induces a false dichotomy in what parents are thinking they are doing versus what is actually happening, that I think is something to sit with when it comes to like having this conversation and having this decision-making process. But then also it does have just the same issues as euthanasia generally, right? Like we have at the end of life, there is the sort of, again, like the cases that seem like much more understandable versus the people who are, you should have
near foreseeable
autism.
Death.
Right. Yeah. But you have like, if you have like very advanced cancer, you're in a lot of pain. Like there are things where you're like, okay, I understand more what, like, you know, what someone would be drawn to in this case versus that. But it's, as a general principle, it's very difficult to like, first of all, to keep something only in those strong cases, right? Like it starts there, but then all of a sudden we have the slide towards general acceptance. And I think you see that with the selective abortions as well. But also it's saying something about like how we are conceptualizing our role as being able to determine that someone else should die, right? And that's something that at Rehumanize we're very uncomfortable with generally. So while I don't think, and I think it's like one of those things too, where when we're talking about this and the parents who are having this kind of decision making, it's not that we think that they have evil intent or they're terrible people or like, you know, like any of these kind of value judgments surrounding that. It's just that if you are making the decision that someone should die, and, you know, based on whatever else, like that has a lot of layers to it that are beyond just like trying to prevent suffering, then they need to be examined and walked through. And the doctors don't do that, right? Like the doctors very much are like presented as like, this is the most caring and compassionate thing you can do. We're so sorry for your loss. Try again, without kind of walking through all of that gray area.
Yeah. So how do we actually know that there is fetal pain at that stage, right? Like, so pain and pain perceptions, you know, you can't exactly go ask a fetus how it's feeling.
Right.
You can't actually empirically test to see if it
right, like
is
what kind
feeling
of pain you're going
or
to
if
have.
it even has subjective qualia or has an understanding of what it
Right.
is in itself. Editing John here, but do you know who does have a subjective experience of qualia and understands pain? That's right, the Against Malaria Foundation, for whom this podcast is raising money. The people who get malaria also definitely feel pain from it. It's very bad, and we want less of that in this world. And to further the ends of ensuring that fewer people experience pain from malaria, this podcast is raising money for the Against Malaria Foundation. So, if this podcast has been helpful for you, or you would like to support me or any of my work, please consider donating to the Against Malaria Foundation. If you do not have the means and you would still like to support this podcast, you can like, subscribe, you can rate and review us. Only good ones, though. So, yeah. Anyway, cool. Back to the podcast. Segue. I'm not convinced babies themselves are particularly conscious, having had one.
Right,
I know
yeah.
they're
But
conscious,
they also,
but
yeah.
like, do they actually understand what pain is and like
right, how are they,
that's
how do they perceive pain?
Yeah.
And that's actually, I mean, that was like a real thing. They used to not use anesthesia on newborns because they're like, they can feel pain. But then, you know, doing brain scans and doing MRIs and looking at how their brains light up in response to different stimulus and the nerve endings, they're like, oh, actually, we're pretty sure that babies can't actually feel pain. And they've extended that down in when it comes to fetal development to, there's some debate somewhere between 13 and 20 weeks is where we feel pretty confident that there is fetal pain based on like the nerve ending development and the signaling in the brains and that kind of thing, that they have some sort of perception of stimulus to brain. And if it is a painful stimulus, that they probably have a conception of that pain in some way. Again, maybe not in a articulable way like we can, but I think in a measurable way when it comes to just the biology and anatomy and all that kind of thing.
Do you think that pain perception becomes more as the fetus develops?
Yeah, it's actually an interesting thing. So, especially because I had a preemie, right? So I had this like conversation with as a preemie. There's sort of a time when the pain is more acute. So for micro preemies specifically, they are very aware of the fact that when you get from like 22 weeks to about 32 weeks, because the pain receptors are sort of disorganized, it can make it so that they have sharper perceptions of pain. So very, very tiny babies can have disproportionate responses. Like they'll have their heart rates will, get higher and that kind of thing. And then as they get older and those things get more organized and more developed, then they kind of start going into a more like adult version of how we would perceive pain if we were having a similar procedure done. So that level of disorganization in the second to early third trimester causes what they think and how the babies act and more like intense. And I actually kind of think about this a little bit in terms going to like autistic people, that sometimes if you have like a hypersensitive autistic experience of pain, like that's a fairly common thing in the autism community, almost like that stage of development is similar to how someone might be like hypersensitive to pain as an autistic person throughout their life.
Makes sense. Makes sense. So is there an argument, do you think, that like, okay, this child, their lungs are like super underdeveloped or something, they will essentially suffocate when they
Yeah.
come out. We don't have anything to do for them. We're sort of going to watch over the next 14 days as they slowly die, or something like that. In my mind, I think an induced heart attack sounds better than slowly
Then the
like
slowly,
suffocating to death.
yeah, there are things that we can do that not necessarily do happen, right? Like one of the things that we do at the end of life for an adult or an older child, if they are having this like perception of suffocation and lung failure, is morphine. Like we do like high dose morphine, and sometimes to the point that in order to support the comfort in breathing with the morphine level is going to be so high that it actually does hasten death. That's something that happens a lot at hospice at the end of life. But the intent is not to hasten death, it is to try to support the breathing. And so measures like that, where you are trying to reduce pain, even if it does result in a death that's maybe quicker than it otherwise would be, is a completely valid way of approaching a situation where you have someone who is actively dying. And I think that having that option as a possibility is helpful. And some prenatal hospice programs are better than other at supporting those kind of things, because I think that's really, for most parents in these situations, their biggest fear is they don't want their child to suffer. Like that is their guiding principle in all of this, is like, I don't want my baby to suffer. How can we reduce the suffering? And so if we are trying to address that, it has to be having a real solution and not just like sometimes, like I have a friend who her daughter was a teenager. She passed away from cancer. And for some reason, the hospital where she was at would not offer terminal sedation to her. And so her daughter was in horrible pain as she was dying. And the doctors refused to do it. And she was like, why won't you do this? It's legal. Like, what is the calculus here? And they couldn't really explain to her. And so she had a terrible last few weeks of just agonizing pain when there was terminal sedation is a accepted method of pain control there that they weren't using. And so when we refuse to offer those things, of course it's going to drive people towards either some sort of assisted suicide, or during the pregnancy a termination for medical reasons, because they're like, well, that's the only way I can stop them from suffering, so this is what I have to do. So that's really a judgment and a policy decision at the hospital level, that if we're really serious about preventing suffering, we need to be having more of those conversations.
Yeah. That makes sense. Yeah, so then moving on to the next sort of type of selective abortion. People look at something like Down syndrome and go, well, it obviously sucks to have, don't want a kid with it, don't want to deal with this stuff. Isn't it just better to start off, just start new again? I don't want to suffer, this child is going to suffer, blah, 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 blah.
Right.
They'll probably live till they're in their like 40s, 50s, maybe a bit longer than that. But ultimately, this is going to be a bad time for everyone. Why bother?
So When it comes to that, I think that there are kind of two things that are involved here. And I mentioned that we got a lot of comments when we was posted about this at Rehumanize. And some I think are more honest kind of like responses. And some are a little bit of, I think this so that I don't have to actually really consider. So I'll start with the more honest, not necessarily like super well. So if someone says, look, I don't have the capacity to raise a child with special needs. Like, I know myself, I don't have the patience, I don't have the resources, I don't have the family connections. Like, I can't have a kid who has any kind of disability. That's just, and especially like what happens when I die. Like, that's just beyond my abilities. I think that's the honest response and something that people are making decisions based on, absolutely based on that. And then there's the, I think, much more dishonest version. Not intentionally dishonest, like they're lying to us, but more like lying to themselves or not being completely honest with themselves, which is, I don't want to have a child because they're going to be suffering from Down syndrome, and that would not be a life that I want. So I don't want my child to have that life. And that, I think, is in part a difficulty with a theory of mind for someone who is born with an intellectual disability. Because when you actually talk to people who have intellectual disabilities and who have for their entire lifespan, they tend to have very high levels of self-reported happiness and satisfaction with their lives and all of these kind of things. But we, as someone without an intellectual disability, think what would happen if we suddenly were in that position. Oh, I wouldn't want to live like that. So therefore, I'm like injecting that value judgment onto a person who might have a perfectly lovely experience in their life and not have any kind of longing for something else. And so when you say, well, I don't want my kid to suffer, from that perspective, I think that we need to be really careful about what we're saying about suffering and what we mean by that. Because again, going back to the, like, your child is going to be born with diminished lung capacity. They're actually like physically going to be suffering. That's a different kind of conversation than my child is going to be intellectually disabled and have some various, correctable health issues.
Yeah. There's a fairly large study that went out where they surveyed around, I'll probably get the numbers a little wrong, but it was something like 5,000 parents who had a child with Down syndrome, and asked them a bunch of questions like, are you proud of them? Do you love them? Is your life better because you had them? Do you regret having them? Are you embarrassed by them? And it found a sort of shockingly low percentage for people who reported negative experiences. It was like 5% or something like that, where 5% actually regretted it, but everyone else seemed to be pretty much fine with it. Of course, it's hard, and of course there are lots of difficulties, but overall, there's a lot of, most people would say things like, it's not as bad as I thought it would be.
Right.
That does get different when it's ASD3 though.
Yeah.
ASD3, very different. We can't screen for ASD3 though, so
we can't.
Yeah, we can screen for Down syndrome, and it is interesting to me that abortion rate is so high, but regret rate is so low. And I wonder, like, is that a selection effect? Is it just the types of people who didn't bother going through the testing and abortion have the child? Or
I think partially, yes. I think that there is a certain kind of person who is going to reject, abortion after getting that diagnosis. And that type of person probably tends to be more like, go with the flow, I'll accept, life as it comes kind of person, which I think tends to be someone who is going to have generally a higher satisfaction. But I think you can also look back to historically, like, what did people think before these kind of screenings became commonplace? And people who have Down syndrome who are now in their 40s and 50s or even beyond that, like, what were their parents' experience like? And there was, society was different, and there wasn't as many supports for, disability rights and all of these kind of things. So they were kind of objectively in a harder place. And even when not from a statistical analysis, but just anecdotally, the people who I know, like, I have one of my mom's cousins has Down syndrome. Her name's Kathy. She was the youngest of 14 children. So it's a very common, like, way of having a child with Down syndrome. In the 60s would be the youngest child of a large family, and had a she's still alive, had a very lovely life. Her mom lived to be in her late 90s, and for the last years of their life they were in a assisted living thing together, just like hanging out. And then after her mom passed away, Kathy still is there, and all of her siblings and nieces and nephews are very involved in her care and her life. So I think if we look back at that cohort and how people feel, when they had these children with disabilities before the screenings became possible, you still see a very high satisfaction both with the child, now adult, and with their families in a lot of cases. And I think where you start losing that insight, though, is if you have kind of the kinds of co-concurrent disabilities that would at that time result in someone being into an institution. So that's where you sort of lose that. And I think a lot of times Down syndrome can co-occur with autism, can co-occur with autism level 3, and that kind of situation, or those children would likely had not been in a family environment back then and are more likely to be today.
Yeah, I often think of the comedian Shane Gillis. He does a lot about living with people with Down syndrome, as he has a bunch in his family, and I think he does some really good bits about them, where people are like, he has this one bit where he talks about how people are like, oh no, he has Down syndrome, and he's like, buddy, these are the only guys having a good time.
Right. Yeah. Literally at family reunions, Kathy's like doing cannonballs into the pool, having the time of her life,
Yeah.
For sure.
Yeah. So there are things like that, but then there's also just the reality that, like, right now, if you surveyed parents who have kids with ASD3, satisfaction rates are probably going to be pretty low. Right. The number of people who are having a good time and other sorts of related issues, like, a lot of these conditions aren't a cakewalk and are very, very difficult to deal with.
Yeah.
And are difficult to manage. And so the question is, like, why shouldn't we at least consider this to be an option?
I think why we shouldn't consider this to be an option is it's basically saying, we are making this subjective judgment of if you, who already exists, life is worth living or not. And so we're taking this very strong power in our hands to say, you are living and I am deciding that you should die instead. I think that your life would not be worth living, or it would be too hard for me for you to continue living. So no. And I think that just as a non-starter, it makes it very problematic to just coming from that premise. But then I think at a deeper level, you start, as you are deciding which conditions are something where you're going to continue the pregnancy versus abort, that list starts getting more and more open to interpretation, right? Like, we're going to talk about, like, we have the anencephaly to Down syndrome or spina bifida to it's a boy or girl, or it's and if you are acting in a worldview that there is nothing wrong with an abortion ever, like abortion is a morally neutral to morally good act, then you can't criticize really any of that, right? Like, then whatever someone's decision to abort is also morally neutral. So aborting girl children is a morally neutral thing to do because abortion itself can't be morally bad. And so we get into sort of these weird ethical bite the bullet situations that people don't actually feel comfortable with, right? Like, most people, if you ask them, like, should we have sex selective abortions? Is it the most you're going to get, the most like dedicated, like, I'm really pro-choice, is like, well, I mean, think about how terrible her life is going to be if she has parents who would kill her to have a boy, like, so it's really a mercy to do that. Like, you have to kind of do some pretzel twisted logic about why it's okay from certain perspectives you would ordinarily be like, no, of course, like, sex selective abortion is overtly a sexist and terrible thing. But only if we can say that any abortions are problematic.
Yeah. So another argument that I hear a lot, I'm not sure how I feel about this one, it seems sort of prisoner dilemma-y to me, is that if you have selective abortions, there will always be some children who will have special needs who just won't get picked up by the screening. And right. So if you don't have these, or if you have these screenings and those children don't get born, what are the support services going to be like for the children that do exist? Like, what if you are the one guy with a Down syndrome child?
Right. You're the only person with Down syndrome in your class and there's no program because yeah. And I mean, I think that's, that's not like, that's a weak argument, but not a weak concern, if that makes sense. Like, obviously you could say like, oh, well, they can just like have great services no matter what. Like, what are you talking about? But in practicality, yes, I think that it is reasonable to say that the knowledge for how to best care for people with Down syndrome and educate them and all that kind of stuff is going to degrade if there are fewer of them. I think you see the opposite of that with autism, right? Like, there's all this research and services on how to best support people with autism right now. And a lot of special needs programs at schools are specifically directed towards autism. And even my oldest son, when he was in special needs, it was that exact dynamic. There were like 6 autistic kids and 1 kid with Down syndrome was the, class makeup. So I
It's
think it's
also
a
because
real
you can't detect autism early
right,
on.
exactly, exactly. And so I think that's a real concern of, that people who have these conditions that are mostly being screened out are going to have fewer supports than they would if there were a larger cohort of them. But I think that it's one of those things where like you can easily come back and say like, well, we should just continue training people on the off chance that they have this, or, like build up those things. So I don't think that it necessarily is like so therefore we should stop prenatal screening or something like that. I think that is the prenatal abortions are wrong enough on their own without needing this extra bit of it. But practically, I think that, if you are a child with Down syndrome in Iceland, like they objectively are not going to know what to do with you in terms of education. Like, you're outside of the Overton window completely there.
Yeah, I find that argument a little weird if you accept that some of these conditions are sort of just your quality of life is just worse. It's like,
Right.
well, we should have more people with a worse quality of life so that we know how to treat them better.
Yeah.
I find the logic of that very weird, where it's like that doesn't quite compute to me. I don't quite see the through line here
Yeah.
of
I mean,
why
like,
you would want more people in the category of suffering so you know how to better handle fewer people with the suffering. It doesn't quite compute to me, but anyway.
Yeah.
I thought I'd bring that up because I'm sure someone is going to.
Right. No. And I mean, I think, again, like if you are the parent who is trying to get services for your child and you're like, there's just nothing anymore. Like, no one, I understand that being like, you know what, if more people were having children with Down syndrome, this would not be. And I think that's a reasonable thing to think and feel, but I don't think it necessarily like logically comes to the conclusion of it being allowable.
I also think there's sort of just a overall broader societal effect in how, like you said about like drift, right?
Mm-hmm.
So the way, I think that is a reasonable concern, that things do drift over time and your sort of window of what's acceptable versus what's not acceptable changes based on your current circumstances. And so there's this argument that we should actually push right and like make sure that we are the least inclusive or the least accepting of any sort of practices like this, so that we don't eventually drift to the left and accept things that would eventually become unacceptable. I think about this conversation I had with my coworker that I was telling you about before this podcast, where he visited Utah, and Utah has significantly more children with Down syndrome because they're Mormon, and so they are far more or far less willing to abort a child that has Down syndrome. And he was commenting, he's like, they're just everywhere. You see them all the time. It's so weird to like go out and just see people with Down syndrome. And he was saying, and like, isn't that a strange thing that you are seeing so many children with Down syndrome? But I also think that sort of affects society as a whole, because
Absolutely.
when you don't actually see people different from you, start to think about people who are different from you quite differently. And like a lack of exposure to diversity does hurt people who are diverse or on those divergent paths.
Yeah.
What do you think about that sort of
No, I
argument?
think that that's definitely the case, that we are exposed to far fewer people who are, have like visible disabilities, intellectual disabilities specifically now than in the past, because there are just fewer who are being born. And it's funny, the Mormon thing, I have a friend who, she is Mormon, and she is a military spouse. And so they found out that one of her children was going to have Down syndrome between a PCS. So they were like changing between, different care providers. And they found out that her son was going to be having Down syndrome. And I think it was like at 21 weeks, and the law at where they were was 22 weeks, that they could legally have the abortion. She was getting a lot of pressure to have the abortion, even though she was like, I don't believe in this. Why do you keep she had to, be like aggressive and say, if someone tells me to have an abortion another time, I'm going to file an official complaint about this because I have been very clear that I don't want to have this abortion. But because even within the TRICARE system, they were heavily pushing it because they're like, buy now, time is running out. You have, and so she felt a lot of pressure about that. But in her community, having a child with Down syndrome was not seen as like this huge catastrophic thing. She just was accepting it as one of her 5 children. So I think that is a very real thing, is like community and community dynamics. And if you see one of your friends has a child who has Down syndrome or some other obvious condition and they're living a perfectly normal, lovely life, that makes it seem much more doable for you to do that. So I think that part of seeing fewer children with Down syndrome and fewer people with disabilities in the world does make a big difference on just what people think a normal life looks like, right? Like going back to like my mom's family, like having a cousin with Down syndrome was like a normal thing growing up. I think for a lot of families, especially a lot of big families, like that was a normal thing. It didn't think too much of it. So then if you are going to have a child with Down syndrome, you have like a warm, normal association. But if that's never been part of your life experience, you've never been experiencing anyone who has Down syndrome, and you're told you're going to have a child with intellectual disabilities, especially if you're coming from a place where having intelligence is highly valued, and all these kind of things, I can see how it would make it a much scarier proposition than if it's a more normalized part of your life.
Yeah. So I think that's an important thing to note as well. But that this sort of dovetails into something that you just said, which is that in their communities, that's a normal thing. And in a lot of these places, they also have supports and places that you can send your children and sort of social apparatuses to help you with your developmentally disabled child. And if you aren't in a situation with that, it is terrible. Right? Like children themselves are hard. Children with developmental disabilities are way harder in almost every respect. And one of the things that I find very frustrating about this discourse is that I know you guys don't do this, but there are people who are like, it's a crisis that you have so many abortions of Down syndrome children in Iceland. But also, if you dare talk about increasing social services or the social safety net, I will come to your house and stab you, type of thing. And
right.
Yeah, like
not the position of Rehumanize International to be clear here. We're very supportive of social services, but no, it is a real thing, and I'll tell you, like, I experienced it. My little son has autism, like I said, and at the time we lived in Texas, and when he aged out of the early care intervention program, it's supposed to be taken over by the school district, right? Like that's like up to 3 is ECI, and then 3 to on is through the school district. So we were trying to get him evaluated through the school district to continue things on. And they just sort of kept dragging their feet and wouldn't approve him and just would not get the ball rolling. We just called and called and called. And eventually we were just doing private therapy elsewhere because it was very clear that they were not going to do what they needed to do. So he starts kindergarten without having any kind of evaluation. It's an absolute disaster, all of these things. Turns out, I learned later, that the reason this happened, because the state of Texas was sued, is because they had an unofficial cap on the percentage of students that they were allowing in special ed. And so they could have, 2% of their student body being special ed, because it was tied to like some funding things. And of course, this is extremely illegal, right? But they were doing it. And the way that they kept that cap was just by not evaluating students for special ed. We were caught up in that. We didn't realize it until years later, and is, beyond the point of taking any action. But yeah, they just straight up just weren't going to evaluate him, because how can you tell he has autism if you never look at him, right? So yes, that is a real concern. Like being able to access services in schools is a real concern. Being able to access services beyond school is a real concern. It is very difficult to have the kind of supports after you are age out of the school district, which is 21 here in the US. Those are real issues that do require to have a social response to it and a community response. And we actually talk about this in terms of abortion generally, about the asks, because it's different than other social things. Like a lot of social, you're trying to get someone to support whatever cause. it doesn't have a big cost to that person, right? Like if you're saying like, I think you should really support gay marriage, right? Like that could have a cost of like, if you're a religious person, you're like, well, I oppose that and that. But you could say, but look, it's going to improve these other social conditions that are totally unrelated. And don't you want people to have more stable relationships? That's good for you too. And you're like, oh, well, I have my concerns, but yes, that's something that at least it benefits me tangentially. So, okay. But when it comes to abortion, you're really asking something of a lot of people. You're asking something of the women and the family specifically, especially in situations like this with someone who has a disability. But you're also saying to the community, you also need to be doing something and taking part and supporting this family. And that's where a lot of things fall apart, because it's like easy to be like, oh yes, that's good, I'll support you. But when you're like, no, you personally need to support the policies that enable this to happen, you get a lot of pushback and a lot of discomfort for people. So it doesn't just fall on the family. It really is something that the responsibility for caring for people with disabilities, intellectual disabilities, really does fall on all of us. And that's something that we have largely decided to abdicate. So that's a social failure as well.
So how do we change that? What do we do about it? Because
like, what do we do? Well, you should join.
One of the things that I'm like constantly yelling at people about is they come up and they say, yo, we need systemic change. We need to do blah, 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 blah. And it's like, okay, well, we don't live in a world in which that's happening. And so,
right. So
given that we don't have alternatives and we don't have anything, this seems like a thing people are going to keep doing.
Right. Like, what do you actively do? And I mean, and part of it is using the legal system. Like the reason that changed in Texas and they can no longer just overtly is because a parent was like, I am suing you. I am going to sue you to make sure this happens. And I know that, Americans get a reputation of being sue happy, but when it comes to your child's educational needs, it can have a widespread effect, right? It can help your individual child to get access to services, but also have a impact on other children or other families. So like, actively taking part in those kind of legal structures, as uncomfortable as it is something that specifically families who are affected, but also more widely, supporting those families, that we can do like today. If you know that your local school district is not providing services to children with disabilities, you can sue them. So I jump to that because it's something that it really is actionable and has an impact at the, at least your like local community level. But then beyond that, it's, hey, let's look at what kind of like world we are wanting to build. Like what kind of insurance coverage? Are we supporting Medicaid expansions? Are we supporting Medicaid cuts? What does that mean? If you have I live in Louisiana, so we had a pro-life Democrat for the last 8 years who did a big Medicaid expansion. Now we have a pro-life Republican who tore it all down. Like if you are someone who especially is pro-life, use that. Use where you have the kind of connection point to your elected official to pull them to the place where you're trying to get them to go. So like, hey, Jeff Landry, you say you're pro-life. Why are you cutting Medicaid? That's not a pro-life position. I am your core constituency. You are betraying this. We're going to go there. And that is, you can find some point of agreement with literally any politician on, that you can be like, hey, as a whatever American who agrees with you here, what are you doing on this? So being more actively engaged like that has benefits, like using those kind of issues. And then when it comes to like building out active supports, that's something that I think that the church actually can in cases do very well and in cases do badly. But I have literally gone to a church where we had like extreme theological disagreements because they had a special needs respite care ministry. Okay. Like they literally like had my son drawing a picture of like Noah and a dinosaur building an ark. And I was like, you know what, but you're doing respite care. So like, we're going to roll with it. So that's something you are true story. So if you are part of a church ministry, if you are part of a church team, building a special needs ministry is like a hugely impactful thing that you can do that doesn't require politicians or lawsuits or anything like that. I probably should start with that, but that's something that especially, members of faith communities can do that is extremely impactful for people who are raising children with, and, young adults with special needs.
Yeah, that makes sense. The final thing that I want to touch on, which is sort of related to this, that I just wanted to get your thoughts on, is germline editing and the ethics of taking pre-implanted or pre-implantation embryos and genetically altering them and genetically modifying them to deal with these sorts of anomalies. If we get to a point where we can deal with it consistently. Is that something that we should do?
So I was just looking at a thing. There's a ethicist, Wesley Smith, who was talking about this specific thing a few days ago, and where he landed is like we shouldn't do it at the germ layer level, but if we have like CRISPR technology to do it at the post delivery level, like that would be a less problematic way of doing things because it ensures like the still healthy development. Because I guess the concern is that the germline is that it can be potentially destructive if it's, and then you're moving on. So there was some concerns about, I think, the how successful it would be and how you would probably potentially be introducing like destructive technologies into it at the germline. I feel not, I guess it's like, again, when it comes to any kind of embryo, like there's a lot of weird stuff happening right now in the world of embryo tech, I guess. Like there's, like ability to take two embryos and take information and make like a third embryo that has like the best qualities, and people are doing that kind of thing, which is obviously
Hell yeah.
like we're like, no, then you're destroying too. Like what are we doing? So I think it's very, very easy to like start spinning off
Doing science.
This dystopian world that's, again, like we're like destroying people to make super people. Like, yeah, they're like, so your child is actually genetically like maybe you're like great times 3 grandchild after all of this. So it's very easy to go hard dystopian. But when it comes to like, can we take out one extra chromosome? And that is like what we're trying to do. I think like if we're just looking very, very narrowly at that specific thing, I have less issues, especially if it's to make them, then you plan to have this child go on to, develop and be without any kind of issues as their lifespan continues. Less issue with that. But I do think it's a very ethically murky area where I have suspicions. I guess that's probably the best way. I have suspicions. And I'll say I have suspicions there. But I have like my broader concern is less on that specifically and more on the I'm going to make 30 embryos and choose the very smartest, tallest, bluest eye one. That's really where I have the primary discomfort and like moral abhorrence towards, versus potentially maybe doing gene editing at a specific embryo level.
Yeah, that makes sense. All right. Do you have anything else you wanted to add to this conversation before we cap it off here?
Yeah. So the last thing, just going back to my thoughts at that very last point of like choosing the very best and brightest embryo, and then destroying the rest, is I am extremely concerned about how being like the chosen one will impact children going into the future. I think that like if there was hypothetically a way that they could do this without destroying any other embryos and like super sperm, like there's all kinds of, like I said, tech has gotten real weird right now with them in like the future. So hypothetically, they could do this without destroying any embryos. You've just created this magical, brilliant embryo. I still have concerns. And my major concern there is like, what does it mean for your parental expectations and who that person actually is? Because if they were created to be the smartest and the best and the most successful, and all of these huge parental expectations have been put on them, and then like they're not, right? Maybe they're really brilliant, but like their largest goal in life is to be a used car salesman. Like, how is that going to affect you as a parent and like what you expected from them? And how are you pressuring them to live up to this, first of all, financial investment, but also all of these like things that you have imbued inside of them because you chose this specific category of traits. So I have very major concerns how that's going to play out. I feel like it's very much turning procreation into a commodity. I think that it's just not something that is healthy for a child to have that much of their parents, not just hopes and dreams, but financial input into making them be like this very specific type of person that they may or may not actually end up being at the end of it all. So that gives me a lot of pause.
Yeah, I think there are just general issues with commodifying children and treating them more like designer products you paid for rather than human beings that exist in your life.
Yeah.
And I think we're quickly jumping off the cliff. It's not even a slippery slope.
No, it's just like,
Cars in mid-flight right now.
yeah, they're just going for it. Like I think I saw
Yeah.
like the oldest child who's like had this happen is 7. So we're just like these, new generation of Gattaca kids, and we'll see how. And I feel like it's kind of twofold too, because one, you have the fact that your parents actually literally chose you into this, but also you have the kind of parents who would do that. So you've got like two kinds of pressure coming at you, and yeah, and obviously those parents would also very much be the kind who would definitely have abortions if they found out there was any kind of fetal anomaly. So I think it's a similar cohort, if not an overlapping circle.
Yeah. Yeah. All right. I think that's a good place to cap this off. If you would like to find me, my name is John. You can email me christianityonthespectrum@gmail.com. You can find me on Twitter @ChristianityOn. You can find me on Blue Sky @ChristianityOn.bluesky.social. You can also find me on Substack at Dispatches from the Autism Wars and @ChristianityOn. Lauren, you.
Yes. Yes, and I am Lauren Pope. You can find us at Rehumanize.intl.org is our website, or at Rehumanize.intl on all social medias. And then me personally, you can find me at CLE_Lauren on Twitter and Instagram. If you follow me on Instagram, you're just going to see like 3 pictures of my cats. Like, it's very interesting, but it is technically there. So.
Nice. Yeah, so also this podcast has a fundraiser for the Against Malaria Foundation. If you feel so inclined, please consider donating to the Against Malaria Foundation on behalf of this podcast, as it really helps me motivate me to do this work and see tangible results from what I'm doing. We've raised, as of recording, over $26,000 for the Against Malaria Foundation. So that's statistically like 4-ish children saved, which is really cool. 4 kids probably won't die because of malaria thanks to this podcast, which is a nice thing to think. But anyway, that is all. See you later.